Hi, everybody. I'm Mike Saag. Welcome to the webinar here for HIV 101. We have some demographic questions going through that we'll start with. So while we're kind of waiting to get formally started, let's go ahead and answer these demographic questions, and then we will go ahead and start the webinar. The first question relates to your academic training. Second one, you scroll down to answer the three different questions. Um, how many individuals are present under your direct care? And then what proportion of your clinical time is spent caring for people? We'll give you a few minutes to do that, and then we'll get started while we wait for a few more people to join. There were about 800 plus people who signed up for the webinar, so we're going to give it a few more minutes, a couple minutes for people to join in. But while we're waiting, please uh, fill out the demographic questions for us. Thank you. Yeah. Okay, we're hitting up to 200. Why don't we go ahead and get started? I'm Dr. Mike Saag from the University of Alabama at Birmingham, and joining me today is Dr. Judy Currier, who is from the University of California, Los Angeles, which is a northern suburb of San Diego. So it's a typo here on the intro slide, but Judy's at UCLA. And Dr. Melanie Thompson, who's very seasoned practitioner at Thacker and Thompson in Atlanta and has been chair of the IAS-USA guidelines in the past and is still a member of that panel. And we're going to present sort of basic principles of HIV management. And this is really geared for folks who are kind of new to the field. So those of you who are, say, advanced practice nurses or PAs or new physicians that are just jumping in to HIV medicine, this is kind of going back and hitting the basics. And I think you'll find it to be a very valuable hour and 15 minutes. Next slide, please. So the conflicts are listed here for all of us. And the planners have a review of all the slides. The webinar is funded by HRSA, the U.S. Department of Health and Human Services, under a specific grant that ultimately comes to the IAS-USA. The IAS-USA is accredited by the ACCME to provide continuing medical education for physicians, and this this event will have a maximum of 1.5 category 1 credits, but we also are able to get ABIM MOC points for physicians who are trained through the American Board of Internal Medicine. We also have CME for nursing contact hours, for pharmacy and pharmacotherapy credit. So your background should be able to be covered by this, and so you're going to be getting CME credit. I'll explain at the end how to do that. Now, we will have some poll questions throughout each one of our talks. So just like it did at the beginning, the poll question will come up. You click on what you think is the best answer, and then we will move forward from there. If you have questions, which I hope you do, during the talks or at the end, there's a Q&A button, not the chat button, but the Q&A button. Please submit there, and that way we can manage it. The chat will just send questions directly to moderators or commentary. So we'd rather you not use the chat to talk to us or submit questions, but you can use the chat to discuss with other attendees. So feel free to do that. Next. All right. This is for me. This is the demographics. We have a nice mix of providers and pharmacists and educators. So thank you for that. As far as experience, it looks like there's a fair amount of experience with the group. So I'm going to go ahead and share my screen. Let me set that up. And I'm going to go here, share, set up. Okay. So hopefully you should be seeing a single slide, or are you seeing the primary slide at this point, I hope?
Yes, we are.
Great. Thank you, Amy. All right. So fundamentals of antiretroviral therapy. This is, to me, what makes the practice of medicine fun. It's not just learning the rules, but understanding the concepts, the biological principles that drive the rules of what we do. So I'll go through the rules. I'll talk about some of those biological principles as we go. I've been a consultant for American Gene Technologies, which is looking for ways forward for cures of HIV, and really is not directly related to this presentation at all. So today we're going to cover the pathogenesis of HIV and that biology, the life cycle. We're going to go over what we do on an initial assessment of a newly diagnosed person, and discuss the general approach to initial antiretroviral therapy. Dr. Currier will go into what happens after that point, and then Dr. Thompson's going to talk about a lot of the primary care issues of how to manage the patients that we see. So here's the first question. At steady state, after initial HIV infection, they've had a acute seroconversion. Now we're several months down. The viral load is detectable. How many virions are produced in a 24-hour period? Go ahead and make your selection. Okay, let's see what the results are. So it looks like we have a wide variety. I will go over the results, or you'll see what the results are at the end, and you'll have a post-test question that will come to you separately, that you will have the same question. And then the second question is, if you have a 23-year-old woman who's 3 weeks pregnant and HIV test is positive, her HIV RNA is 12,000 copies per mil and a CD4 count of 456 cells per microliter. She has no underlying medical conditions and no concomitant medications. Which of the following do you think is the best option for antiretroviral therapy? I'll just select one. So go ahead and vote. Okay, let's see what we got. Okay, it looks like the majority is either dolutegravir or bictegravir based, and we will go over the answers throughout the presentation. So, all right, so let's get back to basics. This is the pathogenesis of HIV. We start in that same patient I described who's got an established infection, not on treatment, has a lot of cells in the body that are producing HIV. And the target cells are not the resting CD4 lymphocytes, but rather uninfected activated CD4 cells. So these HIV cells kick out viruses. And to answer that first question, it's 1 to 10 billion with a B. 1 to 10 billion viruses a day are produced every day in an infected person who's got HIV, and they're in their body, they're producing 1 to 10 billion viruses a day that over time come down and infect the activated CD4 lymphocytes, which is really less than 2% of the total population of CD4 cells. And then these come up and replace the cells at the top that die off. So at the top of these cells, they live on order for only a day, just a day on average. And they die off and are replaced precisely by a newly infected cell in that 24-hour period. So you have this vicious cycle of cells being infected, producing a lot of virus that's infecting another cell about the time that those cells die off. The key point here is that when we give antiretroviral therapy, what we're doing is we're protecting the activated CD4 cells from becoming infected. And that when that happens, because the cells at the top only live for about a day or so, as they die off, once you give the antiretroviral therapy, they are not replaced by a newly infected cell, and the viral load drops pretty precipitously because what we know is that these cells at the top, the number of cells in the body that are producing virus is directly proportional to the viral load. So somebody who has a low amount of virus, they don't have as many cells in their body at that moment in time as someone who has, say, 1 million copies or a high number, and they have many more cells in the body that are producing virus. The other take-home point is with the antiviral therapy, antiretroviral therapy, it does nothing to the cells that are already infected, but rather blocks virtually 100% of the target cells from becoming infected. So that's a really critical principle. And when you think about it, that's why it's so important for antiretroviral therapy to be maintained consistently. That's why adherence is so important, because if you stop therapy, take that blockage away, over a period of a couple of weeks, the virus can return. Now you say, where does it come from? If these top cells are dying off quickly, the answer is a very small population of latently infected CD4 cells that do not die within a day to 10 days. Rather, they live for months and years. So think of them as embers of a fire that when you've got antiretroviral therapy in place, then they can spit out some viruses now and then, but that doesn't catch on. But if you take the antiretroviral therapy away, these cells can, over time, produce a little bit of virus that could reignite the fire and starts that vicious cycle up again. So what we'd like to do is use multiple drugs targeting more than one mechanism of viral replication, because we've learned, and I'll talk about this towards the end, that if you use a single drug, monotherapy, if you will, one drug to treat, the virus can work its way out of the protection of those infected cells and resistance can happen. And I've already mentioned maintenance of full adherence to therapy is really important for long-term success. So the drugs that we have attack at any one of these parts of the life cycle. There are some drugs that affect binding of the virus to the CD4 receptor or the CCR5 co-receptor. Once the virus gets in the cell, its RNA, its genomic RNA, gets converted to double-stranded DNA through that enzyme known as reverse transcriptase. So we have nucleoside reverse transcriptase inhibitors and drugs that affect not the nucleosides, but actually the enzyme itself, and those are called non-nucleoside reverse transcriptase inhibitors, and those are known as NNRTIs. Once the virus converts to DNA, it goes into the cell, into the nucleus, and then integrates into the host genomic DNA. And that's why those latent cells can live so long with that latently infected, HIV DNA integrated into the host. And that's through a process called integration. And then as it produces a new virus, the components of the virus as coded for by the DNA of the virus coalesce on the surface of the cell, and as the virus is released into the surrounding environment, it matures through the action of a very specific protease enzyme, which basically, remember, proteases cleave proteins into component parts. It's like going from proinsulin to insulin. Here you have a long strand of protein gets cut, and as that gets cut, the proteins become functional, and you've got a live infectious virus. So we can target anywhere from blockage, reverse transcription, we can block integration, and we can block this maturation process. But when you think about it, all these things have in common is that they don't have any impact on a cell that's already got DNA integrated. Rather, it just protects this uninfected cell from either becoming infected, for blocking integration, or the neighboring cell from becoming infected with this newly produced virion, because it's not mature and is not infectious until the protease cleaves those polypeptides into single protein products. So one of the questions that came up over the years is when to start. And initially with AZT monotherapy, it was fairly toxic. It protected people with advanced disease, but it really wore out because it was monotherapy. Resistance happened, so we tended to defer antiretroviral therapy based on CD4 counts, and that was the rule. But as we learned in the 90s, that as drugs became more powerful, more potent, and less toxic, we started moving earlier and earlier. There was a very nice cohort study led by Mari Kitahara and Steve Ganji that was produced around 2008 or 9 that showed from cohort data that treating earlier saved lives, and the relative risk of reduction of death was about 1.9 reduction. There were some who thought that a clinical trial was necessary to prove, so they did that. It was called the START study, and remarkably, the relative risk of death was precisely about 1.9. So it confirmed what was initially seen in the cohort study. So now we treat everyone who's infected with HIV, with a few exceptions. That would be an individual who is not ready to start for whatever reason, but we encourage them to start. We want to get treatment started as early as possible, especially for someone who's in acute seroconversion. That is, they've recently been infected. You want to jump on it right away because it can reduce the amount of that latent pool of cells, and it also has clinical benefit in terms of getting people through that syndrome. The people who is still a little bit about debate are so-called elite controllers who are surely infected with HIV. They have HIV infection, but their viral load is undetectable, and you know that they have HIV by looking at HIV DNA assays, and you can prove it. The antibody test also is positive. So for the most part, we're going to treat everyone as soon as we find out about their HIV status being positive. So again, as we see the patients, we have 3 steps. As always, we do a history physical exam and order the lab tests. The IAS-USA guidelines and other guidelines have very specific instructions on what lab tests to get. You can refer to that. If they have an opportunistic infection, we treat that and then start the therapy usually at the same time. There's a few exceptions around that we can get into in the Q&A if you'd like. But we also, if their CD4 counts less than 200, we usually start PJP, pneumocystis prophylaxis. And then again, we're going to start antiretroviral therapy generally right away, with a couple of exceptions for some illnesses like cryptococcal meningitis, where we might delay a couple of weeks, and also for tuberculosis if the patient is not having advanced disease. The CD4 count is interesting because it is the best predictor of relative risk of opportunistic infections or some of the OI-related cancers, and it's used to decide when to start the opportunistic infection prophylaxis. We use the CD4 count. This is an older study from the 80s, basically, that showed what types of infections we usually encounter with a CD4 count less than 200 here with this top blue line. And you see a lot of them, they don't really show up until the CD4 count less than 50. So MAC, Mycobacterium avium, or CMV, we don't hardly see those infections anymore because what gets a little confusing, but it's critical in my opinion to understand, is that while the CD4 count is a relative indicator of risk, it's really the virus at high levels over an extended period of time that causes the true immune deficiency. So if you have somebody with a lower CD4 count and you treat the virus and it goes away, the replication goes away, the risk of OI starts to vanish. One thing to watch for, however, is, so, say you have somebody comes with a CD4 count of 25 and a viral load of 500,000, you treat them. They initially didn't have any signs of an opportunistic infection. And as the viral load comes down dramatically, 3 to 4 weeks after you start, let's say they had an opportunistic infection, but you didn't know it because there weren't symptoms. The symptoms can be brought out by the reduction in virus suddenly, and the immune system, in essence, because the virus isn't around anymore, wakes up and starts to attack the OI that's there that you didn't know about, and that's called the immune reconstitution inflammatory disease syndrome, and that's called IRIS. So you can watch for that if you're treating somebody with more advanced HIV disease. Watch for that to show up, and don't be surprised, but don't be afraid to treat their HIV. Just be on the lookout for exposure of an occult OI that you didn't know about previously. Um, and again, the HIV RNA or the viral load can be up to several million copies, but once you get people on treatment for anywhere between 6 to 12 weeks, that viral load becomes undetectable because you've successfully prevented the infection of new cells. A couple of rules. Use multiple drugs targeting more than one mechanism. Typically, we start with a 3-drug regimen, but we can reduce it to a 2-drug regimen later. Somebody has a lowish viral load, say less than 20,000 copy, less than 50,000, you might start with just 2 drugs initially, but we usually start with 3 and then back off if we feel that it's indicated. We want to maintain full adherence to therapy. We want to start as early in the infection course as possible. We want to treat everyone except for perhaps elite controllers. I personally treat people with who are elite controllers because their immune system's working hard to keep the virus suppressed. And when you give the antiretroviral therapy, you're basically giving air support for the infantry, and you give the immune system a bit of a break. A little bit of controversy about that, but I think a lot of folks are leaning that way now. Low level viremia, as we'll talk about in a minute, is not ARV failure. Rather, what that is that latently infected population up at the top right of that prior diagram spit out virus every now and then, and that virus gets into the circulation, can be detected. So some people don't get less than 20 copies ever, but they may hover around 40 to 80 copies, and that's fine for them. And that's usually a person who has very high viral load to begin with. Absence of a robust CD4 count response is not ARV failure. That's something that happens sometimes, but it's basically not the replenishment, usually from redistribution of CD4 cells that were trapped in lymphoid tissue, and undetectable equals untransmissible, and that includes mother-to-child transmission. So we'll start through all these. I've already mentioned the life cycle of the virus and where we intervene. There's just an incredible number of treatments that are available. Well, these slides will be available to you, but the more modern therapy sort of that we see here, starting really with the integrase inhibitors in 2008 onward, bictegravir, dolutegravir are kind of the anchor drugs for most regimens that we use, and then 2 nucleosides, oftentimes TAF, or TDF, plus FTC or 3TC. We use a lot of, and then there's non-nucleosides like ripivirine and doravirine that we can sometimes use as a anchor drug instead of an integrase inhibitor, or perhaps with an integrase inhibitor. The guidelines here, these were produced by IAS-USA in 2022. Every 2 years, these guidelines come out. They started it back in the 1995-96 era. And it's kind of fun to go back and look at these and see how much progress we've had. We're due for another update that we're working on now that's not accepted for publication yet, but we're hoping in the next couple of weeks if we are fortunate. So the recommended initial therapy, as I alluded to, is usually a bictegravir or dolutegravir regimen. Sometimes you can start with dolutegravir and lamivudine right off the bat, but it's not recommended for a rapid start before you know what the hepatitis B status is and before you know genotype. And the reason for that, while 3TC or lamivudine has some activity against Hep B, it's not very robust, and resistance can occur pretty quickly over the course of 20 weeks. To lamivudine, you can have a flare of Hep B. So you want to know that status before you treat with this two-drug regimen. And you want genotypic results. So if they have a resistance mutation for 3TC or FTC, that means you'd in essence be giving dolutegravir monotherapy, and we don't want to do that. Patients with chronic Hep B are not really indicated for two-drug regimens. Patients with very high viral loads, typically we don't treat initially with two-drug regimen, although we can, once the viral load's suppressed and the CD4 count's coming up, we can switch over to that later. Patients treated for an active OI, we typically use the three-drug regimen as listed in the top two bullets. And of course, we monitor for adherence and virologic response. During pregnancy, going back to the second question that we had pre-test, there's a lot of data now that shows that TAF with either 3TC or FTC plus dolutegravir specifically is the treatment of choice, all things being equal. You can use TDF instead of with 3TC or FTC with dolutegravir as an alternative if either TAF isn't available or they are already on a regimen containing TDF. The same thing is true nowadays for somebody who's already on a bictegravir regimen. That would be BIC plus TAF FTC. If they're already on that and having success, there's now new data that shows that it's safe to continue and not switch over. So the bictegravir, not quite the degree of evidence that says you could start that right away in someone who's pregnant, but in general, it works. And then for the other regimens here, going back to that question, atazanavir is an acceptable regimen. Raltegravir is twice daily, so we typically don't use it. It's another integrase, but atazanavir and darunavir require boosting. And ritonavir is safe for pregnant women who are pregnant, but if you want to use cobicistat instead as a booster, that is not approved and not recommended. So on that question that you saw at the beginning, the last two answers had cobicistat as a choice, and that was an incorrect choice. But 90% of you went for either dolutegravir or bictegravir, and dolutegravir technically, because of evidence, is a preferred regimen, at least till we get more data. And rilpivirine's a decent choice, but we typically use an integrase inhibitor. We treat everyone, and part of the reason for that, as I alluded to, is that when you have somebody who's on treatment, these are inflammatory relative markers, and they tell you how much energy the immune system's fighting. When somebody's got HIV and they're not treated, there's a fair amount of inflammation. When they're on successful therapy, viral load suppressed, it's markedly reduced from the baseline, but it's still higher in general than someone who doesn't have HIV. And so I prefer to treat elite controllers because of data like these. Low-level viremia is not failure. I've already alluded to that, but remember, while you can block this 100%, these cells in the upper right-hand corner can spit out virus and put it into the circulation where you can detect it. It does not mean that the antiretroviral therapy is failing. Well, how are you going to know if it's failing? Because the viral load will start going up well above 200. So 200 copies is kind of the break point, because you rarely, if ever, see this happening where you get spitting virus up to above 200. It's usually less than 100 copies, but not less than 20. So let's focus on this a little bit. This is the way I think about how HIV pathogenesis happens. This is in lymphoid tissue. And this is where most of the transmission of virus happens. And remember, the color codes here would be, this is an infected cell. These are uninfected, non-activated CD4 cells, but here comes along an activated CD4 cell that is susceptible. These guys are not susceptible to new infection, but this guy is. And as it kicks out virus, it comes up, binds, enters, infects that cell. And at steady state, this is amazing. That happens roughly at the time that the original cell dies. And that's why, since we know that viral load is proportional to the number of cells in the body producing virus, that virus is remarkably stable. If their set point, if you will, is 30,000 copies, we can measure it today, a week from now, a month from now, maybe even a year from now, and it's going to be roughly 30,000. But behind the scenes, there's all this churning of virus production, and there's infection and loss of these cells at a remarkable rate. But yet still, that exchange is basically one-to-one. When you give antiretroviral therapy, you're basically putting a force field around this activated cell so that when the virus comes up to infect, it either doesn't bind, it doesn't enter, it doesn't transcribe, it doesn't integrate, and that top cell now is protected. And as this cell in the middle dies off, you get reduction in the viral load, and that's how it works. If you give monotherapy, you have kind of holes in your force field. And if this virus comes out and it happens to have, let's say you're using a non-nuke like nevirapine monotherapy, that'll work against most of the viruses that this guy is producing. But if this happens to be produced with a mutation in the reverse transcriptase, let's say Y181C, now the nevirapine won't protect. And when that cell gets infected, every virus that it puts out has that mutation, and that resistance can emerge with monotherapy in the matter of days after you start the monotherapy and be 100% of the viral population within a month. It's just amazingly how dynamic this all is. So we don't want to use monotherapy. So there's plenty of resources to give you information about resistance. You're not going to be a maven at this early on, so don't feel bad if you don't know all these terms. But a good place to start would be the IAS-USA. There's papers on the not only on the website, but there's a journal that the IAS-USA puts out, and every 3 or 4 years this is updated, but you can go to the IAS-USA website, as you see here, and get kind of a primer on what this means. Another great place as a resource is a Stanford database. If you order a resistance assay, say a genotype, it comes out, and you can plug in the numbers of the resistance mutations, and it'll tell you what drugs are likely to work and which ones are not as likely to work. Just briefly, this is what you're doing. You're doing basically sequencing of the regions where protease, reverse transcriptase, integrase actually act or work, and you have to sometimes order the integrase resistance mutation separately. Those are details. But bottom line is it does a sequence of that, and then when it comes out, this is a type of change you might see. This is a methionine that's in wild type or the usual susceptible at position 184 reverse transcriptase gets replaced by a valine, and that M184V mutation causes high-level resistance to, say, lamivudine and FTC. And then if you go to the IAS-USA website, you can see these are the mutations, and going from, say, M to V in 184 or one of these other changes. We don't have time to go into the details, but just kind of giving you a heads up on that. And also, you can order through some vendors a phenotype, which, think about it like a antimicrobial bacterial resistance assay, where it's not genetic, it's actually does the bug, in this case the virus, get inhibited by the drug in vitro, and you get these type of reports. Don't have time to go into this too much, except to say that like that 3TC FTC resistance you can see here. Interestingly, you get hypersusceptibility to AZT and to some degree to tenofovir. So it actually is more active when there's an M184V But these are more advanced concepts that we'll talk about later. And for integrase resistance, um, you want to keep your eye on the 155, 148, 140 mutations, and then especially for some drugs like dolutegravir, the 263. Again, details that we won't go into much more. And then finally, normally when you give antiretroviral therapy, here you see the viral load coming down nicely to less than detectable. And usually the CD4 count bumps by up to 200 to 300 cells in a matter of months. Sometimes, however, the CD4 count doesn't go up hardly at all. And you look at this carefully and you see that the majority of the bump that got missed was in that first 6-week period. And my interpretation of that is that, as I mentioned already, most of the viral replication takes place in lymphoid tissue. And when you stop the viral replication of billions of copies a day, those billions of copies are inflammatory. It traps CD4 cells in the lymphoid tissue. You stop the replication, viral load drops, and the adhesion molecules made inside the lymphoid tissue are downregulated, and the cells release back into the population. When somebody's had a pretty advanced infection for a while, you treat, and those lymphoid architectures are destroyed to where there's no reservoir of CD4 cells to be re-released. And then finally, very importantly, when you have somebody whose viral load is suppressed and sustained in a suppressed state, you do not see transmission from either mother to child or person to person. So not only by treating your folks early with antiretroviral therapy and they continue the therapy, they will live a normal lifespan or pretty darn close to normal, not transmit the virus to others. And that is just a remarkable statement considering where we were 4 decades ago with HIV. So in conclusion, we understand the life cycle is critical to understanding why we do what we do. Antiretroviral therapy interrupts HIV replication completely, halting the most of the damage done by HIV. Remember, HIV is the cause, in my opinion, of most of the immune system dysfunction. You drop the virus, the immune system returns to close to normal functioning. ARV protects against uninfected cells from becoming infected, but has no effect on an already infected cell. If it did, we would be curing people, and we don't cure yet. All ARV drugs are target specific sites in the viral life cycle. Initiate ARV with an integrase inhibitor, that's integrase strand transfer inhibitor, that's what the INSTI stands for, and 2 nucleosides. Occasionally, you might just use 1 nuke, or you might use an INSTI with an N and RTI, and the timing may be delayed with certain OIs like TB and cryptococcal meningitis. So I will stop there. I will stop sharing my slides. If I can get back to this. And I will bow out and introduce Dr. Currier, who's already on camera and ready to go. And we're going to continue this. Again, reminder, if you have questions, put it in the Q&A, not in the chat. And I'm going to turn this over to Dr. Currier. Take it away.
Okay, great. Thank you so much, Mike. That was terrific. So I'm going to move on to really how we optimize antiretroviral therapy in the setting or for the prevention of comorbidities. And the focus here is not so much on newly diagnosed, but new to you and your practice, people who you first meet who are on a regimen and you think about whether you should change or not. I want to acknowledge Roger Bedimo, who gave a prior version of this talk, whose many slides I did borrow or update, so muchly appreciated and acknowledged. I've served as a scientific advisor for Merck last in the spring of 2024. And the learning objectives are here. I'm going to talk about antiretroviral therapy optimization, some of the comorbid conditions that can impact outcomes, and how we might select regimens for people living with HIV who have primarily increased cardiometabolic and to some extent renal disease risk. So I'm going to start with a case as an important kind of perspective on the kinds of decisions that we have to make. So this is a 65-year-old woman with HIV who was diagnosed 5 years ago. and has a base at that time, had a low CD4 count of 120 and a viral load of 85,000, had wild type virus, B5701 negative, hepatitis B, immune, no hepatitis C. And so she had been started on a regimen of rilpivirine, FTC, and TDF, and had been doing really well. Her CD4 count went up to 650, and creatinine clearance was 75. But as she's gotten older, she's developed several health problems, high blood pressure. She's had coronary artery disease, status post an MI, a history of asthma, and then recently diagnosed with some gastroesophageal reflux. She's also sustained a wrist fracture and had a DEXA scan that showed osteoporosis, and she was prescribed calcium, vitamin D, and alendronate. Her primary care provider, who might also be you, prescribed omeprazole and inhaled fluticasone for her asthma. So now she has a plethora of issues going on in medication. She has to take her medication with meals, and she says, "Is there anything else we could do here?" So, which of the following options would you select to help manage her HIV? Continue the current regimen. She's done well on it. Switch her to a single tablet integrase-based regimen with bictegravir. Switch her to a single tablet regimen with dolutegravir, abacavir, and 3-TC, a 2-drug regimen, or switch to a boosted PI regimen. It's a lot to take in. We're sort of heading off with the sort of most complicated case, but I think it gives a good starting place for people to put your nickel down. I should have put something else as one of the options. It's always an option, is something else. So go ahead and vote. Okay. Let's see if we can move on to see the outcome of our vote. Okay, so most people are going with the single tablet regimen with bictegravir. Great. Okay, I think we'll come back to this. Then we have a second patient actually, who's a 35-year-old man with a BMI of 30, a low CD4 nadir of less than 200, who's been doing really well on efavirenz with FTC and TDF for 10 years. And he's very reluctant to change because this regimen really saved his life. But he has some insomnia and a depressive disorder. He's willing to consider it, but wants to kind of know what's he in for if he makes a change. His CD4 count is 700 and his viral load is less than 20. So which of the following weight changes might result from a switch to bictegravir, FTC, and TAF? And go ahead and vote. Okay, I think that's probably sufficient time. Let's go ahead and show the results of the vote. Okay, so he's already suppressed. Looks like a range of options here, but the most common one was the combination of C and D. Okay, great. All right, so we know that HIV therapeutics has really transformed HIV into a chronic disease, and that life expectancy is now approaching that of people similar demographics and age in the general population. These data haven't been updated since 2014, but others, as it keeps getting closer to a normal survival. But this survival is accompanied by an increasing burden of non-communicable diseases, which do occur in people aging without HIV, but they appear to be really more prevalent. And the number of NCDs that an individual person might have. And this was a prediction of what we could expect to see in the future as the population of people living with HIV ages. The higher proportion of people will have 1, 2, or 3 comorbidities. And this is something that we need to really integrate into our practice about how to prevent as well as to treat. The range of chronic diseases are pictured on the slide across really all organ systems of the body. And I think it is important to recognize that these are common conditions in people without HIV, but they may be augmented with the combination of this chronic inflammation that Mike talked about with this battle between the immune system and the virus. So we think that the contributors to these chronic diseases include the host, the genetics, the environment, the virus, as we heard about, but then also the one thing that we might be able to make some control over is the selection of antiretroviral therapy. And that's kind of what I'm going to focus on here. How can we best really tailor the treatment to the individual? Certainly, we want to work on things that we can control in the environment, like diet and exercise, but there are some things that are harder to control. So optimization, people who are virologically suppressed, why we would consider changing their therapy. Well, we might do it to reduce the pill burden or dosing frequency if people are taking treatment long term. Switching to a long-acting injectable for some people does make a significant improvement in their quality of life. We want to enhance the tolerability of the regimen and decrease toxicity. And I talked about some of the areas where there may be relationship between antiretroviral therapy, cardiovascular, bone, renal, and weight gain. We want to reduce drug-drug interactions. Our patient in the first example who was taking rilpivirine and omeprazole is a combination that you would want to avoid. And we want to eliminate any food or fluid requirements if they're challenging. And then ultimately at a sort of policy level, reducing costs as part of could be considered as part of the equation. But our first goal is always to do no harm and to maintain viral suppression. And I think this is so important, and particularly for people who've been living with HIV for decades, who've done very well on initial regimen. The fear of changing is real, and it's something that we have to manage. We want to look back at the antiretroviral history. That's hard to do sometimes when new patients come to your practice with limited records. Some of the electronic medical records have made it easier to get outside records, but I think we all still struggle with finding what the previous resistance testing might have shown. The patient's history can be sometimes incomplete. I've found that pharmacy records can be really useful. If a patient doesn't remember everything they're on, they might remember where they got their medications, and that may be a way to find this out. We want to make sure about resistance. I think, as we'll talk about, there have been a number of studies done switching people who are suppressed, but almost all of them were done on people that were on their first regimen with no prior history of resistance. And that's just not the real world that we live in with people that are coming into our clinic. We want to think about hepatitis B co-infection and as an important comorbidity, and especially when we're thinking about 2-drug regimens that only have a single active drug for Hep B, and then also other comorbidities, and then not a comorbidity, but the potential for pregnancy. So simplification, I mentioned, the single tablet regimens or changes that have been made really have shown over and over again that they were non-inferior to remaining on the initial regimen. And this is a complicated slide, but basically in studies that looked at switching to each of these single tablet regimens from a variety of other regimens, the virologic efficacy was comparable. And I think what's challenging about this, that most of these studies are really focused on people that were on their first line regimen. And all of them are looking at staying on the first line regimen versus switching to one other thing. So we don't really have comparative data about switching to say a bictegravir regimen versus a doravirine regimen or a 2-drug regimen. They're kind of looking at staying the course or switching. But I think it gives us a lot of confidence that we can make changes in people that are suppressed and successfully potentially reduce the pill burden. So what are some of the factors that we might think about? Well, one is bone disease. And I think it's been well documented that people living with HIV have a higher risk of fracture and a risk of low bone density. And this was a study from the Partners Healthcare System, and both in women and men, this is not just an issue for women, it's also an issue for men, showed a higher risk of fracture. And that this really increased around for women after around age 50 and similarly for men. So we also know that tenofovir, TDF, can increase the rate of bone loss. And this were studies comparing directly emtricitabine with tenofovir alafenamide to emtricitabine with tenofovir diproxyl fumarate, so TDF and TAF. So this is an issue for a patient with risk factors for low bone density, where you might prioritize the use of TAF over the use of TDF. Next, what about these two drug regimens? There are a couple of different options for two drug regimens. There's the boosted PI with 3TC, dolutegravir rilpivirine, dolutegravir darunavir boosted with ritonavir, dolutegravir with 3TC or FTC, and then the long-acting injectable cabotegravir and rilpivirine. And they have been shown to be non-inferior to initial therapy, remaining on the initial therapy in people generally who are on their first regimen. So these are great options, except in the case of people who have hepatitis B co-infection. That's the one caveat. And they can simplify treatment and reduce the number of drugs and may limit toxicity. So somebody with bone disease, this would be a way to completely eliminate either TDF or tenofovir from the regimen. So now we have another case, and I think this is an issue that we're all struggling with in practice. This is a woman, 55 years old, who started treatment a year and a half ago with a TAF dolutegravir regimen. Her CD4 count was 325 when she started, and her BMI was 22, so low. She gains about 8 pounds since starting therapy, and she's not happy about it and asks if this is from her meds and what can we do about it. So your choices here are to reassure her and tell her that this happens when you start therapy and talk about diet and exercise, or to say, we're going to switch your regimen to make this weight gain go away. You switch it to doravirine with tenofovir FTC or doravirine with TAF FTC, to long-acting cabotegravir rilpivirine, or phone a friend to do something else. That's my do something else option here. Go ahead and vote. Okay, let's see what we got here. All right, so if half of you are going with option A, and I think that's going to be the right answer, and I'll tell you why for now. We do expect that people will gain weight when they start treatment, and it may vary based on the regimen used and the patient's characteristics. So this is a summary of multiple studies that looked at weight gain after starting ART by antiretroviral class and drug. So on the far left, you can see that integrase inhibitors tend to be associated with more weight gain compared, and this is change in kilograms, compared to NNRTIs and PIs. Within the integrase inhibitors, bictegravir and dolutegravir, significantly more than elvitegravir with cobicistat. And again, look at the absolute values here in terms of kilograms. And then with respect to the nucleoside component of the drug, more weight gain with TAF and abacavir compared to zidovudine and TDF. So we can expect weight gain, and the weight gain that occurs is related to some of the patient characteristics. This is looking at, from the same study, factors associated with weight gain, higher for Black females and Black men compared to others. So significantly higher. And also we've seen from studies that, that the weight gain is higher for people who started with a lower CD4 count. And finally, the other factor for weight gain is where you started with your weight. So people who are underweight when they start treatment, and our patient had a BMI of 22, that weight gain is back to their sort of pre-HIV, where their weight might have been without HIV. So we have to take all those things into consideration. So one of the questions is, and somebody who's on an integrase inhibitor, can we switch them off to make this weight gain go away? And this is a field that's continuing to evolve. And I'm going to show you some of the data about efforts to date to see if we can make a difference by changing. The first one is the DEFINE study, which looked at switching to a PI after you'd gain weight on an integrase inhibitor. And the bottom line here, the integrase, continuing the integrase is shown here in the red. Basically, the weight stays basically the same, and switching to the PI, there was a slight increase. So there were, most people had body weight changes of less than 3%. Consistent across subgroups. DEXA scans were stable and both remained virologically suppressed, but there was no significant improvement by switching off the integrase inhibitor in this study. Some have looked at a multitude of different studies shown on this slide with fancy names like SALSA and TANGO and SOLAR, looked at changing to 2-drug regimens. If we saw back in an earlier slide that TAF was associated with more weight gain. So what would happen if you took away the TAF? And to date, the studies have been really not significant in terms of not consistently leading to what would be considered clinically important reversal of weight gain. Even with the cabotegravir rilpivirine, the long-acting islatravir doravirine, so far we haven't seen like a big change. And that probably is because the populations of people with weight gain are very heterogeneous. Some are the people who started really low and had a return to health weight gain, and then others are people who've gained additional weight who were overweight to begin with. And it's possible that we're just really missing a signal by including all these groups together. Now, the ADVANCE study was a trial done in South Africa documenting the efficacy of dolutegravir with FTC-TAF or TDF-TAF compared to efavirenz. And this study was one of the first to really highlight the significant weight gain, particularly among women in South Africa with dolutegravir, FTC, and TAF, 8.9 kilograms for the overall group, 5.8 for dolutegravir TDF, and a lower weight gain with in this returning to health situation with 3.3. So they went on to then a subgroup of the study all switched to dolutegravir, 3TC, and TDF. And the idea was, well, maybe that's the best option for mitigating weight gain. And if we just switch people off of TAF, the weight gain will go away. So what did they see? The weight change by sex after this shift was shown here. The females on the left and the males are on the right. And you can see that when they changed in this yellow highlighted area, there was a little bit of weight loss, 1.6 kilograms, in those who switched off of TAF to TDF, stable in those who stayed on, and then a slight weight gain switching off efavirenz. But these are fairly modest changes, and it was more marked in the women than in the men, but these are fairly small given the overall weight gain that we're talking about. Another study that looked at this was a switch to dolutegravir 3TC versus bictegravir FTC TAF. And again, virologic efficacy was looked at, and then secondary outcomes included tolerability, weight, and other metabolic parameters. This study took people on a lot of different regimens, but it did stratify by use of TAF at baseline. And what did they see? They did see that those who switched to the 2-drug regimen here were less likely to have a 5% weight gain. So 20% had a 5% weight gain versus 29.9%. And the change of weight from baseline was slightly less in terms of kilograms compared in the 3-drug arm, but fairly modest in terms of the overall magnitude of the change. So back to our case, I would say that this patient's weight gain were in part likely due to starting ART, partly due to a return to health, and that non-ART approaches at this time really seem to be most prudent. Lifestyle modification, diet, exercise. And I think a really emerging area of research is whether there are things we might do to prevent weight gain in people who are at highest risk of overshooting the return to health. And this will be an area of active research. We hope to see more data about the use of GLP-1 agonists or other interventions that could mitigate weight gain, because I think people are concerned over the long term if these weight changes can lead to other complications, and I'll talk a little bit more about that. One would be hypertension. So there's been a lot of interest in whether integrase inhibitors with their associated weight gain lead to changes in hypertension. And I'm not going to go over all of these studies in great detail. These are mostly from sub-Saharan Africa. Some are also from Europe. And they show basically some level of slight increases in blood pressure, numerically higher changes compared to other regimens, and the clinical significance of this is currently uncertain, but it needs to be continue to be followed. Now, whether the development of hypertension is limited to people who perhaps were more overweight at baseline and gained more weight, I think is an area to further scrutinize. So does this increase in weight or use of integrase inhibitors lead to increase in cardiovascular disease? Well, this has been a really interesting area of research. This was a study of 17 different cohorts that looked at across all people exposed to integrase inhibitors, including people who had switched from other regimens. They looked at the incidence of cardiovascular disease, MI, stroke, and invasive cardiovascular procedures. This is a 21,000 participant cohort. And then they looked at it and they saw that there was this transient increase in the first 6 months after starting that seemed to dissipate over time. And that this was no longer significant in adjusted analyses. And you would wonder if perhaps some of the people who switched to integrase inhibitors might have been at higher risk, and that this was somehow channeled into this analysis. So a follow-up study looked at people who were just starting integrase inhibitors compared to other regimens as their first regimen without having to control for prior therapy. And this was a smaller study. And in the unadjusted analysis, it did look like people started on integrase inhibitors had a higher incidence. But when they adjusted for other comorbidities, they found that this completely went away. And so I think this leaves us with the feeling that there is not an increase, or at least me, with an increased risk of cardiovascular disease due specifically to the use of integrase inhibitors, but longer follow-up I think is going to be needed. So what about abacavir? That's another drug that's been associated with cardiovascular disease. And in thinking about one of our cases where the patient had a prior MI, one of the choices was a fixed single tablet regimen that included abacavir. There continue to be findings that exposure to abacavir is associated with an increased risk of cardiovascular disease. The REPRIEVE trial, which showed that there was a reduction in cardiovascular disease with statins, also showed in looking at those exposed to abacavir that there was an increased risk in that group. And this is shown on this somewhat busy slide, but compared to those with a history of use at randomization and current use, there were higher risks of cardiovascular disease with abacavir, so we tend to avoid that in people with high cardiovascular risk. For tolerability, I think there's a lot of other factors that we can talk about. We talked about bone density, cardiovascular risk. I didn't really have time to talk about kidney disease, but TDF more so than TAF and abacavir. And then we talked about weight gain. I want to just mention finally, avoiding polypharmacy, that this is an important issue, looking at the number of medications that our patients are on and making sure that they're all still indicated. Reducing polypharmacy, I think, is an issue that we need to pay a lot of attention to. And I just want to shout out to the pharmacists on the call of the critical role that pharmacists play in the management of people with HIV. And then this comes into the next issue, which is drug interactions, which I don't have time to review, but there are significant drug interactions with all of the medicines that people are using for chronic disease management. And every time patients are seen, their drug list needs to be reviewed to ensure that there aren't ongoing drug interactions. Finally, cost is an issue, and this was an interesting analysis from a few years ago. The potential savings in the US, if we were to use more two-drug regimens, was over $500 million. So something to think about for those whom it is an option in management. So finally, just to summarize, I think we want to think about switching to people, modernizing regimens when they're suppressed, but there's a lot of factors to take into consideration, the comorbidities and risk for future morbidity. We know people are going to gain weight when they start treatment. Switching to another regimen to date has not really been the most effective interaction or intervention. And we will continue to study the long-term consequences of this and look for ways to mitigate the chronic disease risk. So I want to stop there and apologize for going over by a minute or so.
Great, thank you. That was well done. We're going to move on to Dr. Thompson. I'm answering questions, typing in answers as to the section that I gave as we go to make sure that everything gets addressed. We'll go back to some of those verbally at the end as we have time. But I think it's important now to move on to Dr. Thompson, who's going to review for us the primary care challenges that we have with our patients with HIV.
Well, thank you so much. Actually, I'm going to have a much more focused talk, and this is really only going to be about routine immunizations for adults with HIV. Here is my disclosure, not really relevant to this talk. And my learning objectives for the talk really are to help you understand management of immunizations, focusing on pneumococcal and hepatitis B immunizations, but also touching on a few of our favorite immunizations as well. So here is a pretest question. And please go ahead and vote whenever you feel like it to save a little time as I go through this. So this is a 62-year-old man. He had a PPSV23 as his first pneumococcal vaccine when he was 50 years old. And then when he was 55, he had a PCV13 vaccine. And then he had a PPSV23 vaccine again at age 60. So this is kind of a common patient in our aging population. The question is, what vaccine should he receive at age 65? So should he get another PPSV23 and then a final PCV20 or 21 5 years later? Should he get PCV13 as his final vaccine? Should he get a PCV15 and then a PPSV23 5 years later? Or should he get PCV20 or 21 as his final vaccine? I know those are a lot of letters, huh? A lot of P's and numbers. So go ahead and vote. Okay. Do we have some answers? All right, so most people went with D, PCV20 or 21. We'll cover some of these as we go along. All right, now the next pretest question is about Heplisav, which is also called Hep B CpG. So which of these statements is true about that vaccine? First of all, a full series for previously unvaccinated people with HIV consists of 2 doses given 6 months apart. B, in people without previous vaccines, 77% had a seroprotective hepatitis B surface antibody, which is a titer greater than 10 after 3 doses of Heplisav given over 6 months. C, a regimen of 2 doses of Heplisav given 1 month apart was superior to 3 doses of recombinant hepatitis B vaccine in people with HIV who had not responded to their previous hepatitis B vaccine. And then finally, people with HIV who had not responded to their initial hepatitis B series should receive 2 double-strength doses of Heplisav given 1 month apart. Okay, let's see what you think. All right, interesting. So most people went with C, and that's what I think too. But let's go through and see some of the data. All right. So what's special about people with HIV in terms of immunizations? First of all, there are some vaccines that are contraindicated for all people with HIV. And these are the live attenuated influenza and smallpox vaccines, ACAM 2000, which is also being used for Mpox, but not in people with HIV. And then if people have a CD4 count that is below 200 or uncontrolled HIV, we don't want to give them the live attenuated typhoid vaccine or the MMR, varicella, or yellow fever vaccines. Now, I would just remind us all that people with a low CD4 have a less robust response, and this can improve when the CD4 counts rise. So this is the ACIP adult immunization schedule for 2024, and I want to call out just some special notes for people with HIV. First of all, for the zoster vaccine, there are no longer any CD4 criteria, so all adults with HIV should get the Shingrix series of 2 doses. For HPV, we want to give 3 doses always, and hepatitis A is recommended for all people with HIV. And then we talked about the contraindicated vaccines. And I'm going to go into a little more depth about these 6 vaccines. So we're now in the era of one and done for some people in terms of pneumococcal vaccines. And it is true that a single dose of PCV20 completes any vaccine series. So let's take some examples. For someone who had no prior pneumococcal vaccine, or you're not really sure, you can give them a PCV20 and we're done. You can also give them a PCV15, but that has to be followed 8 weeks later by a PPSV23, and then they're done. So what if someone has had a PCV13 or a PPSV23 at some time in the past? Well, after a year, you could give either of those a PCV20 and they are done. But for the person who got the polysaccharide vaccine, they also would be eligible to get a PCV15 instead of a PCV20, and they also have completed their series. So we have a lot of patients who got a PCV13 and then a polysaccharide vaccine. So for these people, 5 years later, we can give them a PCV20 at any age, and they have a completed series. And for people who are 65 or older, after these vaccines, 5 years, we could give them a polysaccharide vaccine, and then they have a completed series. But there also is a shared decision-making option in which we could give the PCV20 5 years after their last vaccine for people who are at high risk of severe disease or exposure. So here's the new kid on the block. We now have a PCV21, and the serotype map shows 8 new serotypes marked here. And this vaccine was shown to be non-inferior to PCV20 and also PSV23 for the common serotypes, and actually superior for the new serotypes, except for 15C. So not too surprising. Now, PCV21 covered about 80% of the serotypes causing invasive pneumococcal disease between 2018 and 2022. And these 8 new serotypes actually accounted for 20 to 30% of IPD. But look at that box, serotype number 4. That is going to be an issue. So the recommendations for ACIP are that a dose of PCV21 could be given to adults as an option if any PCV is currently recommended. So let's go back to that serotype 4. So it turns out that there is a clustering of IPD that is caused by serotype 4 that has been seen in the West and including in the Navajo Nation. So 30% of IPD caused by serotype 4 in these locations. These are pretty much in adults who are under the age of 65 and have some underlying conditions or risk factors. So in this group, if they've not had a prior PCV vaccine, it appears that our older vaccines may have broader serotype coverage against these locally circulating strains containing serotype 4. So I don't know entirely what to do with this information. It will evolve and we will learn more, but it may be a situation in which one is not done. There is a study with PCV21 that is ongoing in people with HIV. We don't have peer-reviewed publications yet. There are some data on clinicaltrials.gov for the first part A of the study, and that data shows that there is a robust immune response to the serotypes in PCV21. There's going to be a part 2, a part B of this study in which a PCV15 is given at 10 to 18 months after PCV21, and that will be very interesting to see. And so I wanted to give you some resources for pneumococcal vaccination, a QR code. CDC has a web version as well as an app for their pneumorex. So now let's shift to Heplisav-B. The ACTG did a study with 2 parts. The first part was in people with HIV who had never had hepatitis B vaccine before. And this is a single-arm, open-label study. But the data were pretty impressive. So after the second dose, which occurs at week 4, there was a very substantial seroprotective response, almost 100%. And then when a third dose was given at week 24, let's go back. There was 100% seroprotective response. So these are extremely good data in people with HIV, with the caution that the CD4 count was pretty high and most people had viral suppression. So this vaccine is recommended for people with HIV in the new HIV primary care guidance that has just been published. It is actually the preferred vaccine for people who have not been previously vaccinated. But just a reminder, don't give the vaccine during pregnancy because we don't have enough data. And the dose and the schedule is 2 doses at 0 and 1 months, not 0 and 6 months. And you can also use the older vaccines, the recombinant vaccines, but remember that we're going to give these as double strength. And then it's also possible to use the combination Hep A and B vaccine. But just remember, whatever you give, vax and verify. So you want to check those antibody titers 1 to 2 months after the last dose to be sure they have a seroprotective response, which is an antibody titer greater than 10 milli-international units per mil. All right, so this is the second part of that study. It was presented at CROI this year. And this was a randomized study that looked at people with prior vaccine non-response and randomized them to 2 or 3 doses of Heplisav or a 3 vaccine series of a control, which was Ingerix B. And what you see is that both the 2 and 3 dose series were superior to the control. And I also want to show you some subsets. Now, be careful because some of these numbers are very small and none of these are statistically significant. But I think it does give us a hint that this vaccine may perform well in people with low CD4 counts and whose virus is not suppressed. So that is encouraging. And another interesting feature, which is encouraging, is that if you look at the antibody titers after receiving this vaccine, after receiving 3 doses, almost 80% of people had an extremely high antibody titer of greater than 1,000. Now, we don't entirely know what this means. In other studies, it has correlated with duration of protection, but this study is going on, and we hopefully will learn more about that in time. So what are the recommendations for people who have not responded to previous vaccines? Well, we should revax them with a full series. And that would be 3 doses of the double strength recombinant vaccines. The OI guidelines say you could give a 4th dose. There's not really a lot of data for that. Or you could give 2 doses of Heplisav B. And the HIV primary care guidance says that you could consider 3 doses of Heplisav B for people with low CD4 counts or uncontrolled viremia, and then check titers based on the data that you just saw. And again, if you think that people's CD4 is going to be rising above 200, you might consider revaccinating them after that occurs. Okay, let's turn to Mpox for a moment. The ACIP recommendations have not changed for Mpox, and they recommend 2 doses of the Jynneos vaccine. You really have to give both doses, very important, for adults at risk. And here's who CDC says is at risk. They are gay, bisexual, other men who have sex with men, transgender or non-binary people, who in the past 6 months have had at least 1 STI or more than 1 sex partner or sex at a commercial sex venue or an association with a large public event like a pride event in a geographic area where Mpox transmission is occurring. But also remember they're sexual partners of these people, and then anybody who really anticipates experiencing any of these situations. I really just want to emphasize that people with HIV should be prioritized for Mpox vaccination and treatment and use a racial equity approach. This is so important. Remember that 94% of those who died had HIV, and mostly with very low CD4 counts, and that of all people with Mpox, in several series, almost 40% had HIV and almost 70% were Black. Now we'll talk a little about the RSV vaccine. Shared decision-making has gone away. And now the new recommendation is that all persons 75 years or older should get an RSV vaccine. And then for those who are 60 to 74 at high risk for severe disease, they should be vaccinated, and that does include people with advanced HIV, as well as many of the other serious conditions that our patients have. We now have a third vaccine, and that is from Moderna, an mRNA vaccine. Meningococcal vaccines. So in all adults with HIV, we're going to give them 2 doses of the quadrivalent vaccine, at least 8 weeks apart, and then a booster every 5 years. So I want to mention that meningococcal B vaccine is not routinely recommended for all people, but certainly for some people, age 16 to 23, for example, are those who have some other immune defects. But importantly, this vaccine is being studied for gonorrhea prevention. There was quite a stir when it looked like there was going to be efficacy from the Doxyvac trial in France, but the data were reanalyzed, and it turns out that there is no efficacy in that trial to prevent gonorrhea using the meningococcal B vaccine. But there is a separate trial that's going on, so we don't have the last word on this yet. And there is a pentavalent vaccine, which is ABCWY. And if the meningococcus B and ACWY are indicated at the same time, you could use this combination vaccine. Okay, so let's end with COVID, although COVID has not ended with us. Remember that people with low CD4 counts can be seriously affected by COVID, also more likely to get long COVID or to have rapid viral evolution. People with HIV may be 1.5 times more likely to be reinfected with COVID. Now, in terms of vaccination, pretty much the same as the general population, unless they have advanced HIV. And I just want to ping here, it's not a vaccine, but there is a neutralizing antibody, monoclonal antibody for pre-exposure prophylaxis in people who are at risk for severe disease, and that includes people with advanced HIV. This is pemivibart, and it is in the IAS-USA COVID guidelines. So this is the way we vaccinate people with advanced disease, fairly straightforward. And I'm not going to go through all these details, but I am going to give you these references from CDC. These are great tables that go through in detail these immunization schedules for people with advanced HIV. And here are some more references for you. The OI guidelines have a chapter on immunizations. You can get the slides from the ACIP meetings if you're so inclined, as well as their immunization schedule. And finally, I am delighted to announce that the 2024 update to the HIV-MA IDSA HIV primary care guidance is now published. And you can download it for free, and it has some of this information in it. So let's go Vax. Thank you very much for your attention. Sorry, we're running close to the time here.
Fabulous, fabulous. And the first question was, when will the new primary care guidelines get published? So you nailed that right on the head.
There you go.
Dr. Currier and I have been answering a lot of questions in the Q&A. So if you want to go back and see the answers, just open up Q&A and click on answered, and you can see those. But Melanie hasn't had a chance. So let me quickly go through your questions. You're definitely going to get 1.5 category 1 credits for the webinar, because it's taken the full hour and a half. HPV, no matter their age, when do you restrict?
Well, this is for the age range now has been extended, so up to 45. Now, it's also true that most people have already been exposed to HPV early on, so it may have less efficacy, but you can continue to vaccinate up to higher, higher age, and that's very important.
Right. Patrick said recommend the CDC Pneumorex Vax Advisor is a great way to keep up with this as addition to the webinar. Delaney asks, are there any immunizations that have decreased efficacy if co-administered in people with HIV?
No, not that I'm aware of, but I do think we just have to be cognizant of side effects. For example, I would be a little hesitant to give the GSK RSV vaccine at the same time as Shingrix vaccine because they have exactly the same adjuvant. So you could have more toxicity from something like that, but most of these vaccines can be co-administered.
And I think you mentioned this, but we want to generally wait until the HIV is under control before we go into a lot of the vaccinations.
I think for most things, but keep in mind, people do respond. And so, when we're going through flu season or we're going through a lot of COVID surges, just vaccinate people. That may not be ideal, but vaccinate them.
And just a couple more questions. After you've given a hepatitis B series and you check the HBV surface antibody and it's not greater than 10, do you restart the series? Do you go to HepaSlab? What do you do?
So the recommendation is to revax with a full series. And, I think it's going to be studied more closely as to whether or not you could, check that titer. If you've had three double doses of a recombinant, you might be able to get away with a fourth dose of the recombinant vaccine. If you've had 2 doses of HepaSlab, you might be able to get away with a third dose. But that means checking the titers pretty soon after that you've ended the series, not like 3 years later.
Right. And then finally, should someone get an Mpox vaccine if they've had previously recovered from a confirmed Mpox infection?
So that is not recommended. It's felt that immunity is going to be pretty long lasting. So right now, that's not recommended.
Yeah. And I'm sorry, a new question. So this group has seen some non-responders to HepaSlab. What do you do for those patients?
Well, I would definitely revaccinate them with 3 doses.
Yeah. Okay, great. I'm glad that we were able to get to all the questions, even though most of them were answered online. So those of you who are accessing this program through the website and repeat, you can try to see the questions and answers that were done. But I think we're ready to close at this point. Let's see. Yeah. So a couple of follow-up remarks. So the evaluations and information on how to claim CME will be emailed to you by 5 o'clock Pacific time today or 8 o'clock Eastern time tonight. And so that'll take you through. You have to kind of fill out the evaluation to gain access to your certificates. So it's a little bit, what helps us get feedback, which is really important. It's how we keep all this information current. Check the frequently asked questions on the IAS-USA website for follow-up information. Next. So I've been doing this podcast with IAS-USA. We have our 29th episode that just came out. It's called Going Antiviral. And this one's a great one from Jen Cates, who's at KFF, which used to be the Kaiser Family Foundation. They changed their name just to KFF, but she goes into details of the Affordable Care Act and Ryan White Care Act and a lot of really important information. Thank you about the concept of the podcast. Mpox amidst the ongoing global public health emergency, Dr. Currier will be chairing this or moderating with Jason Zucker from Columbia. And that's going to be a great webinar that's coming up. And another one is, where are we with hepatitis C elimination? We're trying to get to 0 there. We have medicines that can do it. And Kara Chu from UCLA is a colleague of Dr. Currier's there. And David Wiles from Colorado will be giving us an overview of that. And that's on November 22nd. Just a reminder that we have a virtual DC course. It's a webinar that'll be on December 3rd in the afternoon, and we'll be talking about substance use disorders, HPV, anal cancer, long-acting drugs for prevention of HIV, reducing the risk of cardiovascular disease, and updates on the latest guidelines for the treatment of HIV infection in adults. And the Ryan White Conference, someone mentioned that as they were signing off. It's going to be November 17th to 19th in Louisville, Kentucky, at the Galt House there, which is that kind of central building that you see in the middle. And a great lineup. About 500 people have enrolled so far, and it should be a wonderful conference. Next. Thank you all for participating, and we'll hope to see you on another webcast in the near future.